Echocardiography in systolic diastolic function EF. Echocardiography is a crucial diagnostic tool for assessing systolic and diastolic function, with approximately 75% of patients with heart failure having a reduced ejection fraction, EF. The pathophysiological mechanism underlying systolic dysfunction involves impaired contractility, leading to a decrease in EF, which is defined as the percentage of blood ejected from the left ventricle with each contraction. Key diagnostic approaches include measuring EF using echocardiography, with a normal EF ranging from 55% to 70%. Primary management strategies for systolic heart failure include the use of angiotensin-converting enzyme inhibitors, ACEi, or angiotensin receptor blockers, ARBs, with a target dose of 10 mg of enalapril daily. Key points. Note, the normal ejection fraction, EF, ranges from 55% to 70%, with values below 40% indicating severe systolic dysfunction. Diastolic dysfunction is present in approximately 40% of patients with heart failure and preserved ejection fraction, HFpEF. The use of ACEi or ARBs is recommended as first-line therapy for systolic heart failure, with a target dose of 10 mg of enalapril daily. Beta blockers should be initiated at a dose of 6.25 mg of carvedilol twice daily and titrated up to a maximum dose of 50 mg twice daily. The serum creatinine level should be monitored regularly in patients with heart failure, with a target level below 1.5 mg per deciliter. The brain natriuretic peptide, BNP, level is a useful biomarker for diagnosing heart failure, with a cutoff value of 100 pg/ml. Echocardiography should be performed at least every 6 months in patients with systolic heart failure to monitor EF and guide therapy. The 5-year mortality rate for patients with systolic heart failure is approximately 50%, with a 30-day readmission rate of 20%. The use of implantable cardioverter defibrillators, ICDs, is recommended for patients with systolic heart failure and a left ventricular EF below 35%. The European Society of Cardiology, ESC, recommends the use of cardiac resynchronization therapy, CRT, in patients with systolic heart failure and a left ventricular EF below 35%. The American Heart Association, AHA, recommends a target blood pressure of below 130/80 mmHg in patients with systolic heart failure. Overview and epidemiology. Systolic heart failure is a clinical syndrome characterized by the inability of the heart to pump blood efficiently, resulting in a decrease in ejection fraction, EF. The global incidence of heart failure is approximately 26 million cases, with a prevalence of 1.5% in the general population. In the United States, the estimated annual incidence of heart failure is 915,000 cases, with a prevalence of 6.5 million cases. The age-adjusted incidence of heart failure is higher in men than in women, with a ratio of 1.25 to 1. The economic burden of heart failure is significant, with estimated annual costs of $30.7 billion in the United States. Major modifiable risk factors for heart failure include hypertension, diabetes mellitus, and coronary artery disease, with relative risks of 2.5, 2.2, and 2.1, respectively. Non-modifiable risk factors include age, sex, and family history, with relative risks of 1.5, 1.2, and 1.1, respectively. Pathophysiology. The pathophysiological mechanism underlying systolic dysfunction involves impaired contractility, leading to a decrease in EF. This is often the result of myocardial damage, such as that caused by coronary artery disease or cardiomyopathy. The molecular and cellular mechanisms underlying systolic dysfunction involve alterations in calcium handling, beta-adrenergic signaling, and the renin-angiotensin-aldosterone system, RAS. Genetic factors, such as mutations in the MYBPC3 gene, can also contribute to systolic dysfunction. The disease progression timeline for systolic heart failure is characterized by an initial asymptomatic phase, followed by the development of symptoms such as dyspnea and fatigue. Biomarker correlations, such as elevated levels of BNP, can be used to diagnose and monitor systolic heart failure. Organ-specific pathophysiology involves the heart, lungs, liver, and kidneys, with relevant animal and human model findings demonstrating the importance of the RAS and beta-adrenergic signaling in the development of systolic dysfunction. Clinical presentation. The classic presentation of systolic heart failure includes symptoms such as dyspnea, 80%, fatigue, 70%, and edema, 50%. Atypical presentations, especially in the elderly, diabetics, and immunocompromised, can include symptoms such as confusion, anorexia, and abdominal pain. Physical examination findings include jugular venous distension, 60%, RALs, 50%, and an S3 heart sound, 40%. Red flags requiring immediate action include severe dyspnea, chest pain, and hypotension. Symptom severity scoring systems, such as the New York Heart Association, NYHA, classification, can be used to assess the severity of symptoms and guide therapy. Diagnosis. The diagnostic algorithm for systolic heart failure involves a step-by-step approach, including a thorough medical history, physical examination, and laboratory workup. Laboratory tests include serum creatinine, electrolytes, and BNP, with reference ranges of 0.6 to 1.2 mg/dl, 136 to 145 millimoles per liter, and 100 pg/ml, respectively. Imaging modalities, such as echocardiography, are used to assess EF and guide therapy. Validated scoring systems, such as the MAGIC risk score, can be used to predict mortality and guide therapy. Differential diagnosis includes conditions such as pulmonary embolism, pneumonia, and cardiac tamponade, with distinguishing features such as the presence of a high-probability V/Q scan, infiltrates on chest radiography, and a pericardial effusion on echocardiography. Management and treatment. Emergency stabilization involves the use of oxygen, diuretics, and vasodilators to reduce symptoms and improve hemodynamics. Monitoring parameters include blood pressure, oxygen saturation, and cardiac rhythm. Immediate interventions include the use of non-invasive positive pressure ventilation, NIPPV, and inotropic agents, such as dobutamine, to support cardiac function. First-line pharmacotherapy for systolic heart failure includes the use of ACEi or ARBs, with a target dose of 10 mg of enalapril daily. The mechanism of action involves the inhibition of the RAS, leading to a decrease in afterload and an improvement in cardiac function. Expected response timeline includes an improvement in symptoms and a reduction in hospitalizations within 6 to 12 months. Monitoring parameters include serum creatinine, electrolytes, and BNP. Evidence base includes the SOLVD trial, which demonstrated a 26% reduction in mortality with the use of enalapril. Key points: pregnancy, safety category C, preferred agents include ACEi and beta blockers, with a target dose of 10 mg of enalapril daily and 50 mg of carvedilol twice daily. Monitoring parameters include serum creatinine, electrolytes, and BNP. Chronic kidney disease, GFR-based dose adjustments include a reduction in the dose of ACEi and beta blockers by 50% in patients with a GFR below 30 ml per minute. Contraindications include the use of ACEi in patients with a GFR below 15 ml per minute. Hepatic impairment, Child-Pugh adjustments include a reduction in the dose of beta blockers by 50% in patients with Child-Pugh class C cirrhosis. Contraindicated agents include the use of ACEi in patients with Child-Pugh class C cirrhosis. Elderly, greater than 65 years dose reductions include a reduction in the dose of ACEi and beta blockers by 50% in patients older than 75 years. Beer's criteria considerations include the use of ACEi and beta blockers, with a target dose of 10 mg of enalapril daily and 50 mg of carvedilol twice daily. Complications and prognosis. Major complications of systolic heart failure include cardiac arrhythmias, 30%, myocardial infarction, 20%, and stroke, 15%. Mortality data include a 30-day mortality rate of 10%, a 1-year mortality rate of 20%, and a 5-year mortality rate of 50%. Prognostic scoring systems, such as the MAGIC risk score, can be used to predict mortality and guide therapy. Factors associated with poor outcome include a left ventricular EF below 20%, a serum creatinine level above 2.0 mg per deciliter, and a BNP level above 1000 pg/ml. When to escalate care/refer to specialist includes patients with severe symptoms, such as dyspnea at rest, or those with a left ventricular EF below 20%. ICU admission criteria include patients with severe symptoms, such as cardiac arrest, or those with a left ventricular EF below 10%. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the use of sacubitril/valsartan, with a target dose of 97/103 mg twice daily. Updated guidelines include the 2020 AHA/ACC/HFSA focused update on heart failure, which recommends the use of ACEi or ARBs as first-line therapy. Ongoing clinical trials include the Paragon-HF trial, NCT 01920711, which is evaluating the efficacy and safety of sacubitril/valsartan in patients with heart failure and preserved ejection fraction. Novel biomarkers include the use of soluble ST2, with a cutoff value of 35 nanograms per milliliter. Precision medicine approaches include the use of genetic testing to guide therapy, with a target of identifying patients with a genetic predisposition to heart failure. Patient education and counseling. Key messages for patients include the importance of adhering to medication regimens, monitoring symptoms, and attending follow-up appointments. Medication adherence strategies include the use of pill boxes and reminders, with a target of at least 90% adherence. Warning signs requiring immediate medical attention include severe dyspnea, chest pain, and hypotension. Lifestyle modification targets include a low-sodium diet, with a target intake of less than 2 grams per day, and regular exercise, with a target of at least 30 minutes of moderate-intensity exercise per day. Follow-up schedule recommendations include regular appointments with a healthcare provider, with a target of at least every 6 months. Clinical pearls. Note: the use of ACEi or ARBs is recommended as first-line therapy for systolic heart failure, with a target dose of 10 mg of enalapril daily. Beta blockers should be initiated at a dose of 6.25 mg of carvedilol twice daily and titrated up to a maximum dose of 50 mg twice daily. The serum creatinine level should be monitored regularly in patients with heart failure, with a target level below 1.5 mg per deciliter. The BNP level is a useful biomarker for diagnosing heart failure, with a cutoff value of 100 pg/ml. Echocardiography should be performed at least every 6 months in patients with systolic heart failure to monitor EF and guide therapy. The 5-year mortality rate for patients with systolic heart failure is approximately 50%, with a 30-day readmission rate of 20%. The use of ICDs is recommended for patients with systolic heart failure and a left ventricular EF below 35%. The ESC recommends the use of CRT in patients with systolic heart failure and a left ventricular EF below 35%. The AHA recommends a target blood pressure of below 130/80 mmHg in patients with systolic heart failure. References: 1. Ding J et al. MYRF gene mutation leading to coronary artery anomaly combined with 46XY sex development disorder. A case report and literature review. BMC Pediatrics. 2025, 1622. PMID, 4081934, https://pubmed.ncbi.nlm.nih.gov/4081934. DOI 10.1186/S12887-025-05853-9. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.